And next up, we have Dr. Laura Lambert, and she is the professor of surgery and director of the Peritoneal Malignancy Program at the University of Utah Huntsman Cancer Institute. Dr. Lambert specializes in the care of patients requiring surgical treatment related to peritoneal carcinomatosis and gastrointestinal oncology. Her main clinical focus is the surgical management of peritoneal carcinomatosis and the use of HIPEC. She's published and spoken extensively on HIPEC as well as the surgeon's role in comprehensive palliative care. I also just want to reiterate that those of you attending today will be able to submit questions in the Q&A feature that is below during the Zoom, and we will answer them and reply to them live during our open forum sessions from 1:30 to 2 and then from 2 to 2:40. So please submit any questions that you have throughout the program today, and we'll answer them live this afternoon. And from there, I will let Dr. Lambert present. Thank you so much.
Great. Thank you, Lauren. Good morning, everybody. And I just want to also thank the ACPMP Research Foundation for inviting the Huntsman Cancer Institute to be a part of this important symposium. Also want to congratulate Dr. Levine and Dr. Vatanopoulos and the folks at Wake Forest on receiving such a prestigious grant for appendiceal cancer. And I would echo what Dr. Levine said, that it truly is a result of all the efforts that the ACPMP Research Foundation has done to bring this to the fore. And I know that their results will benefit not only people with appendiceal cancer, but also people with other types of cancer in similar situations. So we really look forward to seeing what they're able to accomplish with that funding and the research that they have going forward. I'm going to share my screen now, and my presentation is going to be about what's new in 2021 with regards to appendiceal cancer. And I love to give this presentation and kind of have an opportunity to review the literature and share with all of you what's happening in the literature and research and how things are evolving and developing. And Dr. Levine's talk actually hit on a lot of things that are evolving and pertinent in the literature and in 2021. And I always like to start with showing the number of publications that have been published in appendiceal cancer and PMP over the course of the years. And you can see how steadily the numbers have increased over the past few years. While it looks like we may be a little bit low with regards to publications in appendiceal cancer for 2021 relative to 2020, if you look at the rates for PMP, they've actually been equal for the past 2 years, so 2019, 2020, and currently in 2021. So we are projected to exceed that this year. And if you take the combined for appendiceal cancer and PMP, it looks like we'll be consistent with or slightly ahead of the number of publications for 2020. So again, a lot of interest in this area, despite the fact that, as Dr. Levine mentioned, this is a rare disease. There is a lot of interest. People are trying to gather data so that we can better understand this disease and better optimize treatment for it and plan for the future as we're moving forward. And so some of the highlights that were in the literature in 2021 included increased awareness, optimizing treatment, better defining and redefining the pathology, as Dr. Levine mentioned. The WHO came out with new fascicles around appendiceal cancer, which, as he also mentioned, some pathologists use the WHO, some do not. The nomenclature remains very confusing for pathologists, for surgeons who don't see a lot of this. So I would just echo his recommendation that if you end up with a diagnosis with a tumor of the appendix, if you can, seek at least a second opinion at a high volume center with a surgical oncologist, medical oncologist who are familiar with these tumors, and the pathologists who are familiar with these tumors as well, and have your tumor reviewed by a pathologist in a high volume center. It's very important. It really impacts treatment recommendations, prognosis, and outcomes. So please advocate for yourself, advocate for your loved ones, and get the information that you need. Don't worry about offending somebody. This is important, and you just need to get the right information for yourself. We're constantly working on how to improve patient selection, especially for cytoreduction in HIPEC, as Dr. Levine mentioned. It is a major surgery. We want to offer this to people for whom it's going to be beneficial, and we want to avoid doing it on people for whom it's not going to offer any benefit, because it is such a major undertaking. And as he also mentioned, there are new things coming all the time: immunotherapy, systemic therapy, personalized medicine options, looking at the genomics of these tumors. So we're really, really working on identifying the best treatment option for the individual person based on the information that we can gather from these studies that are coming out. We continue to look to advance surgery and intraperitoneal treatments. As you know, this tumor tends to remain confined to the abdomen, which gives us a unique opportunity to really explore different ways of treating these tumors. We continue to investigate the tumor genetics, like Dr. Levine showed, and just there's ongoing research continually. So it is a very exciting time, and there's a lot happening. The ACPMP Research Foundation mission is really fourfold. Number one is to increase awareness of this disease, and they certainly are doing a great job at that. It's also to provide education to surgeons and pathologists and medical oncologists about, and to patients and their families as well, about how best to treat this disease. They are obviously supporting research in a wonderful way, and have been the greatest supporters of research in this disease for a long time. And they're about optimizing treatment. And so those are the things that, as I went through the literature for 2021, again, there were over 300 publications already. I really wanted to focus on some of the articles that highlighted the mission of the ACPMP Research Foundation. And with regards to awareness, as Dr. Levine mentioned, while this is a rare disease, the incidence truly is increasing, and that has come up again with a number of publications in 2021, as well as people trying to identify risk factors to increase awareness that a person might have a cancer of the appendix when they go in to have an appendectomy for another reason. Because as he mentioned, it's very rare that we know ahead of time that this person has an appendix tumor until we take out their appendix. So as he said, we call that an incidental finding. We took out the appendix thinking there was appendicitis, and there was this tumor as well. So is there a way for us to predict that better ahead of time and have kind of a heads up that this might be what's going on, so that, as one of the questions that came up in the chat, the surgeon will be alerted to look around more if there's a higher concern or likelihood of a tumor being there. This study from Cancer in 2020 was one that I presented last year that showed the increasing incidence of appendiceal cancer in the US and Canada. These were huge databases that the authors looked at, and showed that across all age groups in both the US and Canada, there was an increase in the presence of adenocarcinomas of the appendix significantly, depending on which age group you were in, from 44 or 45% up to as high as 451% increase in the incidence. And this trend has continued. So there are a couple of publications this year by Shannon et al. At the University of Pennsylvania. They went back and looked through, again, another large database, the NCDB, over a 10-year period from 2006 to 2015. They found that there were 8,778 appendiceal cancers identified. 4,233 of them were stage 1 to 3, which was 64%, which meant that 36% of people had a stage 4 tumor, meaning that it had already spread outside of the appendix, most likely in the abdomen. These tumors rarely go to other places, fortunately, but they can. So this was most likely people who had cancer that had spread in the appendix. And what they found was that there was a much higher incidence in the second half of the time period that they studied. So from 2011 to 2015, 68% of the tumors that they identified were in that time period. And they found that the people that were most likely to have them were over 40 years old. And if you were over 60 years old, you were more likely to have what we call a T4 tumor, which means that the tumor has actually broken through the wall of the appendix. And now you're at higher risk of developing a recurrence in the abdominal cavity. And that more patients were in that time period were likely to have had HIPEC at some point. And so I think these are important points. It looks like we're increasing awareness about the role of HIPEC, so more people were having it. We're also becoming aware that people who develop what looks like acute appendicitis in older age, older meaning older than 40, are, the general surgeons need to be aware and the pathologists need to be aware that this is somebody who is at a higher risk of potentially having a tumor associated with the appendicitis. Similarly, this is not confined to the United States, so I do think this is a global problem. They've seen the same thing in Australia, where they noticed a 415% increase over a much longer period of time, over 30 years. And some of the reasons why the authors postulated about what might be driving that are the increased use of CT scans. So we're seeing more abnormal appendixes before people present with symptoms either related to the appendix or that the appendix there's a cancer in the appendix and it has spread. The growing aging population, which we're also seeing here in the United States. And they also hinted at improvements in pathologic assessment of the appendix, which Dr. Levine referred to too. And there was a publication that came out from a group down at Mount Sinai in Miami Beach. This was from the pathologists down there. And I would encourage the ACPMP group to maybe consider putting this on their website if they haven't already done so, looking at the rising incidence and asking the question, does the pathologic handling of the specimen actually play a role in what we're seeing in terms of the rising incidence? So they looked back from 2010 to 2020 at all the appendectomy specimens from their institution. It was almost 1,600. And they found a strikingly high percentage that had tumors in them, so 6.5%. And they similarly found that this incidence increased so that in 2010, the incidence was 5.6%, but in 2020, the incidence was almost double that, or it was double that, 12.7%. They found that there was a 2.8% incidence in just acute appendicitis, so somebody who was brought to the operating room for the presumption of appendicitis, almost 3% incidence, which is still higher than what I think most people expect. And obviously it was higher if the person was being taken to the operating room to have their appendix removed because it looked abnormal and there was a suspicious lesion. But at the same time, at that institution, they changed their pathologic assessment of how they looked at the appendix under the microscope. And so we'll show you that in a minute, but what they postulated too was, the other questions they asked were, are we seeing more tumors of the appendix just because we're doing more appendectomies? And actually what they found was that's not the case. The rate of appendectomies, if anything, has not increased over the last decade, but actually decreased significantly last year due to the COVID pandemic. But there's been a real push in amongst the general surgery community to consider not doing appendectomies for appendicitis, but for treating them with antibiotics. And if the appendicitis resolves, you can avoid a surgery. Obviously, there's a concern there because you may be missing a tumor of the appendix if that's related. And so that's important. It's important that general surgeons are aware of this higher incident in people who, especially in people who are older, who present with appendicitis, where you may think about treating it with antibiotics, but now maybe you should really be thinking about taking that appendix out to make sure there isn't a tumor. And so then again, here's the rising incidence that I mentioned earlier. And what was also interesting, and Dr. Levine talked about this as well, is that we used to think that it was carcinoid tumors that were the most common tumors of the appendix. But in fact, this study also showed, at least in this patient population, that it was the non-carcinoid epithelial or the adenocarcinomas, the mucinous tumors that are higher in prevalence than the carcinoid tumors. So in this study, 56% of people had non-carcinoid epithelial tumors, or the adenocarcinomas or the lamins, those other tumors that Dr. Levine was talking about, and only 23% actually had the carcinoid. So there's definitely, that is also something that pathologists and general surgeons need to be aware of when they're taking care of people that come in with a problem of the appendix. And this is what this group has done. They've done what we call serial sectioning of the appendix. A lot of places will just take the appendix and they'll just cut it in half at one spot and kind of look and see there's appendicitis. And if there was a tumor down at the tip that wasn't obvious either to the eye from the outside or feeling it, they may not actually see that if it's very small. And so this group has undertaken a process of slicing the appendix up in 5 different slices. So they're really looking through the whole appendix. And this can also be important because, as we'll see in another study that I'm going to talk about, oftentimes these tumors can perforate, and we think they have the ability to reseal themselves. And so it may look like the appendix there's no perforation, but somehow cells have gotten outside of the appendix. So clearly there was either a perforation or the tumor has grown through the wall. And unless a pathologist is really reviewing the entire specimen, they may miss that site and understage the tumor in the appendix. So I think this is a really important educational point and an awareness point for pathologists and surgeons. With regards to the risk factors, there were a couple of publications that came out looking through large databases to try to determine risk factors for appendiceal cancer. The first study, which was done by Stopansky et al. From the University of California at Irvine, looked at a large quality improvement database called the NSQIP database that is sponsored by the American College of Surgeons. And they looked at all the appendectomies that were performed over a 2-year period. There were over 21,000. They only found a 1% incidence of cancer in those specimens. But they did note that, again, the rising age put people at an increased risk for a higher incidence of an appendiceal cancer. They also noted that if the person did not have an elevated white blood cell count, which is often a sign of infection, which goes along with more garden variety appendicitis, that there was a higher likelihood of having a tumor present that was causing the symptoms. And if it took the surgeon more than an hour to take out the appendix, then that might be a sign that there was something going on more than just, again, garden variety appendicitis. And so these are things, again, for general surgeons and pathologists to be aware of as they're operating on people for a problem with the appendix or looking at the appendix under the microscope. And then similarly, Skandalis et al. From a number of different medical centers in New York City looked at the NSQIP database over a 9-year period, as well as the experience at 2 hospitals located in the Bronx. And they found a slightly higher incidence of appendiceal tumors in their hospitals, 1.7%, and a lower incidence in the NSQIP database over that longer period of time, 0.5%, which is what Dr. Levine quoted. And they also found that there was a higher incidence with age. So again, the age thing keeps coming up. And what they found in their study was kind of interesting, that if you looked across, this was from the 2 hospitals in the Bronx that they looked at, that the incidence of the epithelial tumors, the non-carcinoid tumors, like we talked about, definitely goes up with the higher age group. So 40 and above, you're starting to see fewer of the carcinoid tumors and more of the low-grade mucinous neoplasms and just the frank adenocarcinomas, the real cancers of the appendix. And even in the 90th decile, the 80 to 89 age group. So if somebody presents with appendicitis in their 80s, you really have to have your antenna up that there could be a cancer. And this is not somebody you just want to treat with antibiotics. You need to take out their appendix if they're fit enough to have that done. And then also this year, Peltrini et al. From Naples, Italy, from the Department of Health there, put together a meta-analysis. So they looked through all the literature that published on what we call complex appendicitis, where there is an abscess or a lot of inflammation around the appendix, where the surgeon might be leery about taking the person to the operating room right away and want to treat the person with antibiotics up front. and then take the person later for what we call an interval appendectomy. So that's usually about 6 to 8 weeks later, after the inflammation and infection have settled down, to make the surgery easier and safer for the person. And what they found was that with people who had presented with complex appendicitis, that there was an 11% incidence of a tumor being involved in that. And other studies have shown that as well. This is a slide that I presented last year reviewing this literature, a number of studies that showed as high as 30% incidence of a tumor in somebody who presents with complex appendicitis who goes on to have that interval appendectomy at a later date after being treated with antibiotics. And so again, this is definitely a patient, a group, a population where people really need to have their antenna up that there could be a tumor, that the appendix should come out as soon as it's safe to do so. And again, back to the, one of the other core missions of the ACPMP Research Foundation about education. And really the goal for that is to optimize management. And there were a couple of important studies, I think, that came out this year that are really helping us try to educate people to optimize management. And this was a study by Hayes et al. From the Swedish Medical Center up in Seattle, where again, questioning that need, is interval appendectomy really needed? So for people who have that complex appendicitis, do we need to go back and take out the appendix? And the answer is yes. So this was over a 10-year period. They looked at 402 patients who had complex appendicitis, and in that interval appendectomy, they found almost a 10% incidence of neoplasm. And again, you can see here that rising incidence with age, 43% in people who are over 80 years old. And also they noted that if the surgeon had to, so most people, when surgeons go to take out the appendix, we routinely start laparoscopically, if at all possible, meaning using small incisions in a camera and small instruments. And for the vast majority of the time, we can get the appendix out that way safely. But if a surgeon has to convert to open, meaning they have to make an incision because the surgery is it's not safe to proceed laparoscopically, it's very difficult. That's another indication that there might be a tumor present that's making the surgery more difficult. And the surgeon needs to be aware. If that's the case, they really need to take a good look around the abdomen. The pathologist needs to be looking very carefully at that appendix. This is a study that came out of the group it's actually a multi-institutional study. 7 institutions participated. The lead authors were from the University of California at San Diego. And they wanted to determine who's at risk for recurrence if they've had a tumor that's removed, what they call localized tumor of the appendix. And they looked at localized, specifically Lambert, so the low-grade mucinous neoplasms, over a long period, almost 30 or over 30 years. And they identified 217 people who had localized Lambert, meaning that there was no obvious evidence that it had perforated and spread through the abdominal cavity at the time of surgery. Median age was almost 60%. 60% of the patients were female. They had a good long follow-up, 51 months. And what they found was that there was actually a very low incidence of recurrence. This is the good news. Only 7 patients recurred. They did so within, on an average, about 14 months, although the span ranged from 2.5 to 47 months. And there were 7 patients who had a positive margin, meaning that when the surgeon took out the appendix, we often use staplers, and we sent the appendix was sent to the pathologist. When the pathologist looked at that margin where the appendix was divided to separate it from the colon, there were some mucinous cells, tumor cells at that margin. Oftentimes there will be a recommendation to go back and resect that margin to make sure it's clear. But what this group showed, that even in the setting of positive margins, there were 0 recurrences related to this tumor. This data is supported by other studies in the literature from earlier time that have showed a similar finding. And so personally, in my practice, I've no longer recommended going back to resect a positive margin for this type of tumor. So again, something, to be referred to a high volume center for somebody who sees this all the time and knows this literature to get the optimizing the best recommendations for you. This is the flow sheet of this study. Here's the 217 patients in the middle. And then they looked at how they were treated. So 124 just had appendectomy, 26 had appendectomy and a resection of the base of the cecum, or the part of the colon where the appendix comes off. And 67 actually went on to have, formal resection of their colon, really auspiciously to test the lymph nodes in that area. But what we know about these tumors, and the authors make this very clear, is that they have no capacity to spread to lymph nodes. And so spreading into lymph nodes, doing a colectomy to test lymph nodes for this type of tumor really shouldn't be recommended. If it requires a colectomy to remove the appendix, then that is a different situation. And so the authors show here the rate of recurrence with the different approaches, and showed that doing a colectomy did not improve the risk of recurrence. Once the tumor cells have spread outside of the appendix, taking out the colon doesn't prevent a recurrence in the abdominal cavity. What they did find was that all of the recurrences were associated with perforation. And they also looked at the presence of the mucin, whether it had cells or not in it. And they found that, that there were patients who had recurrences without cells, some with cells, and some with no mucin and no cells outside the appendix. So again, this comes back to that idea of, if there are cells and there are mucin outside of the appendix, there has to have been some sort of breach of the appendiceal wall, whether it was a frank perforation or just some migration, pushing of the mucin through the appendiceal wall. Because as you can see over here, in these groups where there was no perforation or no known perforation, there were patients who had cells outside the appendiceal wall. And so again, coming back to that very thorough investigation by the pathologist, who can pick up a perforation that is not necessarily seen by the surgeon. Here's another very important topic that I know the ACPMP Research Foundation has been interested in pursuing and optimizing, and that's for female patients who are misdiagnosed with an ovarian tumor up front and then undergo large pelvic operations only to then find that they had an appendicial tumor and should have really been recommended to have a different approach to their treatment. And this was a group, again, also down in, 3 institutions across the country, who looked at the number of, over a decade, identified patients who had cytoreductive surgery and HIPEC for appendicial neoplasms, and then went back to see if they had who had had prior pelvic operations for GYN malignancy. And out of 36 patients, they found that 18 of them, or 50%, had actually had a previous operation for presumed GYN malignancy. And what they found was that when these patients got to cytoreduction and HIPEC, they actually had a higher PCI. So Dr. Levine reviewed the PCI, that grading of how much tumor there is, 21 versus 9, and the highest score is 39. They had a higher blood loss at the time of surgery, 650 mLs to 100 mLs. They had a longer length of stay in the hospital, 12 versus 8 days, and a higher rate of complications. So really, really important, ideally, to make the proper diagnosis before somebody has a major surgery, like the women have for ovarian cancer. And the next aspect is, the clinical. This is really the frontier. I am just going to highlight one study by Berger et al. This is from the University of Chicago, and Dr. Taraga, who will be speaking to you, is one of the authors on this study as well. And this is, I think, really kind of the frontier of where we're going clinically, not only in appendicial cancer, but other peritoneal surface malignancies, looking at the role of intraperitoneal chemotherapy with or without heat. And this was a study that they published this year looking at the use of what they call iterative HIPEC, meaning multiple HIPECs without cytoreduction for patients who had high-grade adenocarcinoid cancers or goblet cell cancers of the appendix that could not be removed surgically. And they identified 7 patients for whom they performed this treatment. And what they found was that the average survival for these patients who had the iterative HIPEC was almost 25 months compared to 8 months with systemic chemotherapy alone, and 16.5 months with patients who had cytoreduction and HIPEC. And here's some illustrative pictures. I hope this projects well, where you're looking to see the response in the peritoneum before HIPEC and before the third HIPEC. So these patients would have up to 3 HIPECs. And you can see all these white spots on the left diaphragm here, how they're sort of fading away over here, as well as this white plaque-like lesion here down in the pelvis. And you can see that it's fading away here. And I think this is the most dramatic image here. This whitish plaque-like looking area is tumor on the right flank or the right side of the abdomen. And here you see, this is what normal peritoneum looks like. So you can see that these iterative HIPECs were having a direct impact on these tumor implants. So more to come. This is, again, I want to reiterate, this is a very highly selected group of patients at a very high volume specialized treatment center. So, but more to come on this. This is the frontier. This is where things are heading. And the research is really the future. And I know we're going to have a talk on the Bronack trial and the status of that, but I wanted to just highlight this one study from the University of Pittsburgh, who is taking this Bronack approach one step further and looking at whether the bromelain and the N-acetylcysteine that can break down that mucin that these tumor cells make and help expose the cancer cells that are there, the cellular part of it, to chemotherapy and make them more sensitive. And that's what they were able to do in both what we call ex vivo, meaning in tissue culture, and in vivo models. So in animal models, they treated mucinous and non-mucinous tumors with the bromelain and the N-acetylcysteine or Bronack, with or without chemotherapy. And they found that the mucinous tumors were more resistant to the chemotherapy because they were protected by that mucin and the chemotherapy couldn't get there. But after they treated with the Bronack, the cells became more sensitive to the chemotherapy. They were able to remove more fluid because they've liquefied that mucin so you can extract it. And they found that the tumor burden was less. And here's a couple of, this is just a figure from their study showing that when they added the Bronack to mitomycin C, they had a higher rate of cell death. And here's some actual pictures from that study that showed this is what the mucin looks like. Again, kind of that apple jelly consistency. And then when you treat it with the bromelain alone, it really doesn't have as much of an effect. When you treat it with N-acetylcysteine, it doesn't have much effect. But when you treat it with the combination, you get this really liquefying effect that can then be extracted. And they also saw this in the animal model. So here's a control rat actually with a high volume of that pseudomyxoma and mucinous tumor. This was an animal that was treated with the Bronack, and you can see here that volume of tumor is much lower. They were able to extract more fluid. It was more liquid. And here's when they surgically removed the tumor, you can see the decrease in the volume. And I know Dr. Levine's going to be talking to us about this study and its status in the United States in a future session. And so I just wanted to, there was another question that had come up in the Q&A that there are now 7 clinical trials that are appendicial specific that are open and recruiting in the United States. You can find those on clinicaltrials.gov, and also the ACPMP Research Foundation keeps an updated list of those trials. And, you know, again, the literature is just showing that the data is continuing to reflect what we're seeing in terms of the incidence of appendiceal cancer. And we just need to keep working with the ACPMP Research Foundation to increase awareness about appendiceal cancer so that we can optimize management. And I can't stress, like Dr. Levine did, the need for early referral to a high volume center of excellence for this disease. And that the next generation of treatments is really starting to unfold. You know, we're constantly being asked, you know, is there anything new? Is there anything new? Slowly it's coming, and things are evolving still. And the research continues, and the research is going to inform us and keep pushing that frontier of clinical options that we have. And so I just want to leave everybody with the message that there is hope. Things are moving forward with the support of the ACPMP Research Foundation, with this new funding from the NCI, which is fantastic. And I just again want to thank everybody for the opportunity to speak today and look forward to the roundtable.